All right, I have a question for you, Ranjit. Can deep vein thrombosis occlude an arterial circulation?
It could. If you look at DVT on a spectrum, at the worst end of the spectrum, we see rarer conditions like phlegmasia alba dolens, also known as PAD, and phlegmasia cerulear dolens or PCD. Phlegmasia alba dolens or PAD is what happens when there is an acute large clot burden sitting in the deep venous system with intact superficial collaterals. Because of this, our limb has to rely on the superficial collaterals to drain the blood back. This system isn't equipped to carry the increased amount of blood flow, and because of this, the patient we see has an acutely swollen, pale, painful limb. PAD in turn can become PCD. It's the same as in it's got an acute large clot burden in the deep venous system, but there's also occlusion of the collaterals. And because of this, there's severe venous congestion to the point that it's almost like an acute limb ischemia that turns into necrosis, and you can also get gangrene. PAD and PCD have high mortality and morbidity, in which PCD is a life threatening and limb threatening condition. So, Noel, let me ask you a question. Can a patient who's on anticoagulation get PE?
The short answer is yes. So, a lot of studies and clinical trials have shown patients getting venous thromboembolism, including pulmonary embolism, on patients who are already on an effective anticoagulants. So the exact number or the percentage of people who will get a PE is unclear, but it significantly depends on quite a lot of factors, such as the patient's condition, like hypercoagulable state, or patient factors such as the anticoagulant used, the dosing, the interaction, and the compliance of the medication. So, remembering that, we can't completely rule out as P in a differential when a patient presents to you who are already anticoagulated. Said that, a patient who has an effective anticoagulation for venous thromboembolism, the recurrence is significantly reduced up to 2 to 3% per year. So regarding the scoring system, the PESI score in particular does not include the acute right ventricular dysfunction or doesn't include the cardiac enzymes in it. With the lack of that, how do you think that would influence us using the PESI score in a clinical setting?
So, NICE guidance doesn't actually talk about this, but there's a lot of literature around this topic. There are studies that came out in 2021, 2022, and 2023, which all say the same thing, that combining PESI score, which is Pulmonary Embolism Severity Index, along with cardiac biomarker like troponin I, helped in better risk stratifying patients with PE and also predicting mortality in normotensive patients with PE. So it's a useful tool. It's something to consider, combining PESI with troponin. In the trust that I work, we actually use PESI score by categorizing patients into class 1 to as lower risk, that they can be started on anticoagulation and sent through an ambulatory care pathway. So we book for a CTPA as an outpatient, and then they get followed up in ambulatory care unit. Whereas patients with higher PESI scores of class 3 and above, they have to be admitted and have their CTPA done inpatient. Now, for instance, if a patient has a low PESI score, but their cardiac biomarker, the TROP, comes elevated, I would risk stratify this patient as a higher class and get this patient admitted because evidence says that they carry higher mortality. So, pregnancy in itself is a risk factor for developing VTE. With that being said, when we have a patient who is pregnant and we clinically suspect that they could have PE, what are our investigations at our disposal to rule in or rule out? Because as we know, physiologically, D-dimer is elevated in pregnancy.
So basically, we say and we think that D-dimer is quite useless in pregnant ladies. So we don't tend to do that or use that as any way to exclude a PE in a pregnant lady. But said that, I do want to bring something into this conversation. This is a validator tool called YEARS algorithm, YEARS, YEARS algorithm for pregnant ladies. In this, we can use D-dimer to rule out PE on a pregnant lady. So this has 3 clinical questions in it, looking for signs of DVT, looking for hemoptysis, and looking for PE as a most likely diagnosis. Even if you have all no on these 3 clinical questions, if the patient is pregnant and the D-dimer is more than 1000 nanogram per milliliter, you cannot exclude PE. Currently, our options are if you clinically suspect a pregnant lady to have a PE because she's tachycardic or tachypneic or a pleuritic chest pain, then your only option is to go for an imaging. But now, if we can somehow use this validated tool and incorporate the D-dimer according to the algorithm, and if it is less than 1000 nanogram per milliliter on a patient who has no other clinical signs and symptoms, we can safely exclude PE without putting her through an imaging. Maybe this is something we can look into and see how this can help us preventing unnecessary imaging and the radiation and the risk that comes along with it to a pregnant lady and the unborn baby. So, can a patient get PE without any underlying lower limb DVT?
Yes, PE can occur without detectable DVT in 10 to 30% of cases. In these cases, the emboli can originate from pelvic veins and also veins of the upper limbs. Also, PE can occur in situ, which is also known as de novo PE. There are many factors. Some can be local, so there can be local inflammation, or there can be more systemic complex factors that are seen in malignancy, or the patient could be having an autoimmune condition such as antiphospholipid syndrome. So we have oral anticoagulation, DOACs, and there are parenteral anticoagulation. In the clinical setting, which patient gets what?
Regarding the treatment, we tend to start people on DOACs such as apixaban on most of the ambulatory patients. It's easy to disperse the drug and it doesn't need any kind of a bridging therapy with any parenteral anticoagulation. So we in practice tend to give that on patients we are suspecting venous thromboembolism. Said that, not all DOACs are one size that fits all. Such as dabigatran and edoxaban does need bridging therapy with parenteral anticoagulant. So the drugs we're specifically talking that doesn't need those would be the apixaban and rivaroxaban. Warfarin is not completely out of the picture. Maybe not something we use it more commonly, but it has its uses. For example, warfarin is used in conditions such as patients with prosthetic valves, antiphospholipid syndromes, and with a higher risk of upper gastrointestinal bleeding. Parenteral anticoagulation such as subcut low molecular weight heparin, we tend to use it more when patient is getting admitted, has an oxygen requirement, for example, or a pregnant lady or malignancy-related PE. For any reason they're coming in, they tend to get parenteral anticoagulation. Unfractionated heparin is not out of the picture as it has its own uses too. So certain very specific situation would be in a very severe renal failure patients, we tend to favor unfractionated heparin over the subcut low molecular weight heparin. Low molecular weight heparin multiple studies have shown it is as effective as the unfractionated heparin, but it gives an upper hand in a very predictable pharmacokinetic and its anticoagulation effect. So it's more preferable.